Welcome, ladies and gentlemen, to the fourth match of this season. The Endoscopy Premier League has been a super duper season which encompasses science and sports. This is the only platform where the world's best players have come today together, and we are going to have a power play. Thank you so much. This is brought to you by Sun Inca and Science Integra. I welcome my umpires today, Professor Narendra Malhotra. He's a professor at Dubrovnik International University, past president of ISPAT, ISAR, SAFOG, a great doctor, you can say a very humorous personality, and he has agreed to be with us today as the umpire. Next. Well, I would like to call upon our second umpire, Dr. P.K. Shah, sir. He is also a professor and he is the past president of FOXY, MOGS, IFUMB, and IAG. Thank you for being with us today. Well, we have our power play, and we have the first power play with Dr. Prakash Harikant Trivedi. He is a pioneer in hysteroscopy and laparoscopy, and he's also the past president of FOXY, IAG, and currently is the president of ISAR. A great teacher, orator, committed to his profession, and a great human being. And with him, against him, is Dr. Kiran Koilo. We are going to have a wonderful power play number one. In-bag morcellation versus retrieval of the specimen by the vaginal route, which is going to be told by Dr. Kiran Koilo. She is the chief coordinator, Department of Obstetric Gynac, Leelavati Hospital and Research Center. She is a consultant obstetric gynac at the Holy Family Hospital, Hinduja Healthcare Surgical Faculty at the CMAST, has got 35 years experience and a teaching experience of over 25 years. Welcome, Dr. Kiran and Dr. Prakash Trivedi, sir. The next power play we have with us, Dr. Nikita Trehan, the managing director of Sunrise Hospital, Delhi, Mumbai, and Dubai. She has been a dedicated endoscopist for the last 15 years, and she has the world record to remove the largest fibroid laparoscopically, 6.5 kg, and also holds the world record for the oldest person operated at the age of 107 years. Dr. Nikita Trehan is going to be with us today, and bidded against her is our teacher of teachers, Dr. Rajendra Sarogi, sir. He is going to talk on bald prolapse repair to be done vaginally, and he is an ex-professor at the St. G.S. Medical College, KM Hospital, ex-honorary and HOD of Dr. R.N. Cooper Hospital. He is himself the director of the Sarogi Group of Hospitals, past president of AFP, of the Malad Medical Association. He was a member of Mumbai Obstetric Gynac Society, managing committee, a great teacher with vast field of interest. He received various prestigious Foxy Korean Award in 2006 and 2007 and has presented more than 100 papers and more than 50 publications in reputed journals. Presently, he is a president of the Society of the Vaginal Surgeons of India, Maharashtra chapter. We are going to hear from him, and against him is pitted Dr. Nikita Trehan. I hand over the mic now to our great umpires, Dr. Narendra Malhotra and Dr. P.K. Shah, sir. He's going to join us soon. And Dr. Narendra Malhotra is joining us through his car. See the dedication. See the dedication. He's just being there, and that's amazing. Thank you so much, sir, for joining with us. Welcome, sir.
Welcome, everyone. Welcome, audience. Welcome to this great EPL, the fourth season 4. We are having fantastic matches, 2 matches on every season. And today we have super experts who are going to talk about on super topics. And the first match is between Prakash Trivedi and Dr. Kiran on in-bag morcellation or vaginal retrieval. And let me get the rules correct to all of you players. It is 7 minutes direct, and in 7 minutes I'm going to just cut. 6 minutes I'm going to say you have 1 minute left, and then you have to leave the field. You have to just stop, otherwise you get negative points. And then you get 2 minutes after the opponent to rebut, and then the expert comments by the umpires in the third umpire, and then we have live voting. Audience, be ready with the voting. You have the voting thing in your laparoscopic morcellation or vaginal retrieval. So you have to vote for laparoscopic vaginal or against laparoscopic. So, and then, of course, after both the matches, we will declare who the winner is. Whoever wins, let the best person win. Everything is allowed except abusing in Hindi. You can hit below the belt. You can do bowl bouncers. You can bowl left hand, under the arm, over the arm, whichever way you want to bowl, but you have to get the other guy out. So all yours, Dr. Prakash Trivedi. Your 7 minutes starts now. It is 6:07.
Narendra, as an umpire, I would request give me 7 minutes, 50 seconds and 1 minute for rebut.
Okay.
Thank you.
If the opponent does not,
I think give me the same.
okay. So they want only 1 minute rebuttal, so they get 8 minutes each. 7 minutes, I'll tell you, it's finished. 6 or 7, Prakash Trivedi, start.
Okay, thanks. It's a privilege to be umpired by Narendra Malhotra with the Niranjan Chauhan show, and the subject is very important. And I have coined the word learn tissue retrieval in bag or wait for the lawyer. And obviously my friend Kiran Koilo is a close friend. So we are not going to fight because we have never fought. So we will not argue, we will discuss. You can read this slide. In the meantime, I will tell you what is the problem in the world. The problem in the world is that everybody wants COVID management as what Trump says. Why? Because it is USA. So US FDA declares something, the whole world, and I have asked to US FDA, I have asked JMIC, and including Trump, they have told that we have no jurisdiction in India. Now, sun doesn't rise accidentally in the east. Best vaginal surgeon, best laparoscopic surgeon, best researchers. Laparoscopic myomectomy is the epitome of controversies, and this controversy has to go down. And fortunately, we have a data of almost 1,000 in-bag morcellation. Now, one Canadian expert clearly pointed out the unintended consequences of FDA warning in 2014 has caused so much havoc in the world that there are patients after patients who are refused surgery for fibroid or large uterus, or if at all they nicely separate the uterus or a fibroid, and they most horribly retrieve the specimen, either widening the belly button, either widening the vagina, or all sorts of things. Tremendous respect for separating the specimen, but no respect of tissue retrieval. Now my opponent is very great vaginal surgeon. So now she is going to remove both the specimen vaginally. Large fibroid, she is also a laparoscopic surgeon, and this is what is going to come. She is going to remove this vaginally. What is her incision? I don't know. From where it will come, I don't know. Whether Schuchart's or Schuchart's will go till the cervix. Now you just see the type of tissue which is going to. There is an head-low position. Now this we are doing in a bag. These are the cases which are doing on regular basis. And see the type of contents. PK sir, yeah, PK, good to see you. See the type of content. So when you are removing this vaginally with an uterus anteriorly, there is a colpotomy, and you don't know whether to suck the muck or whether to remove the head lobe. But she is a great vaginal surgeon. Purandare, Sarogi, and all of them are nowhere in comparison. I don't know how she is going to remove this muck. You can just see how we are going to remove. We in fact removed in the bag through an ovum forceps. She will have to do that something vaginally. How she will remove? God only knows. Now you have to remember that because of this morcellation problem from all over the world, Patients are coming from America, from New Zealand, from USA, because they are telling we'll do nice separation laparoscopically, then I'll widen you or something. That means what? It is a laparotomy. So if you see here, this is a patient from Melbourne, because they don't morcellate. And this is an Asian patient. If you see the patient on the left side, what sort of a tumor this is, nobody knows. This I was doing in a live workshop for IAG, and everybody are watching. And I'm not using even a myoma screw. If you saw on the right, that patient was told that you have probably malignancy or tuberculosis, and she had a nephrostomy done. Now this fibroids, our madam is going to remove vaginally. From where and from how, I don't know. Now forget about that. This is an unmarried girl with a 20 centimeter fibroid. Again, even if she's unmarried or nulliparous, Kiran is going to remove this vaginally. I want to know, that's the ureter, that's not the IVC. So you have to understand that when you do a lot of job laparoscopically, why don't you have the courage to learn? Science is to learn techniques and technology. If you will see the tissue on the left side, which we removed and which we have removed in the back, you can't tell it is sarcoma, you can't tell it is dermoid, you can't tell what it is. But we did this nicely, and it was angiolipoma. Now I don't understand how she is going to remove this anterior and posterior fibroid vaginally. Now if you are born abroad, if you're born in India, this is the crux of the matter. In India, I have removed American patients, 24 weeks uterus, 58 fibroid vaginally with 2 previous Caesar, because I could read the uterine in times earlier, before 2014. So all of us are aware of, nicely the L method and removing vagina. There is nothing new, because all people who come for laparoscopic surgery workshop, they see a lot of vaginal surgery at our place. But when there is a headlock given, who on the earth is going to prevent scatter of cells? And abroad, they are very smart. They say, no, we widen the belly button a little bit. So I once joked them, you widen only to such an extent, it looks like multi-paras vagina at the umbilicus. So we have to remember both this technique, what are the outcome. Now let us see the outcome. Now this was vaginal, that same fibroids which were removed. And after removal of uterus, fibroids and everything, she is a gynec from Kanpur. And she came and she told, sir, there is probably a stump, or there is probably a problem. So vaginal removal, vaginal morcellation, and then we realized that the vault had 5 fibroids at the vault. So this, fortunately, we dissected. And the one who removed to the belly button, see what is happening on the right side. There are thousands of cases of leiomyomatosis. This is not uterus. So widening the belly button, spillage, so extensive leiomyomatosis, we went ahead, we separated all the fibroids, we removed those fibroids at the vault, removed them in the bag. This is what I'm trying to tell. Don't pass your buck to your one skill because you have some other skill. Biggest laparoscopic in-bag morcellation, now we are reaching 2,000. And we have compared, and there we were not worried about sarcoma. We were worried about leiomyomatosis more. And the study is now quoted everywhere in the world. 24 years, Vienna, 71 cases of leiomyosarcoma, none started as fibroids. Current textbook of Novak, fibroid is gene suppression and leiomyoma is gene expression. So both cannot take place together. So basically you have to remember, with all this confusion, what should the gynec do? Stop doing myomectomy. Because America says any tumor can be sarcoma. Or all women with fibroid, you don't know, I can't promise whether the sarcoma will remain or not. Do hysterectomy. But the same America allows
1 minute
artery embolization, MRI guided focus ultrasound, radio frequency ablation because it gives money. So there is double standard. So bottom line in science, you have to remember change, evolution and risk, calculated risk. Art of science is to rise above the controversy. See the controversy. Make your brains work faster. Hands run better. Finally, you are bigger than the controversy. obviously we have to first of all outsmart the lawyer, otherwise the lawyer will come and outsmart all your bank balance. Finally, you have to remember the hype is overhyped. In-bag morcellation can be nicely picked up. There are thousands of people in India and abroad learning. Benefits of laparoscopic minimal access should be provided to all this female. In-bag morcellation can be done at any number of size till 28-30 weeks. Vaginal removal of a specimen of an undiagnosed nature or widening the belly button doesn't
Time
reduce
up.
anything. Thank you.
Time up, sir. Thank you very much. Thank you very much for telling us what Kiran cannot do. So let us hear what she can do. And Dr. Kiran, your 8 minutes will start now at 6:17.
No, 1 minute, sorry. Go back. Yeah, sorry. Okay, so thank you, umpires, and of course, my worthy opponent, Prakash. Now I will try to disprove you and tell you how I will do everything. The hospitals I work. So we know that transvaginal uterine and specimen retrieval and morcellation is described right from 1890. And vaginal hysterectomy, as you well know, is the first minimal access surgery that we have done. And all Indian surgeons are very good vaginal surgeons. When Prakash and I were residents together at Rajawadi, readers and APs at Nair, all of us did non-descent vaginal hysterectomies up to 16 to 14 weeks. And we taught our residents so. And since then, everyone has been doing vaginal retrieval. After Harry Rich in 1989 started his laparoscopic assisted, then again everyone was doing a vaginal retrieval of all the uteri. And then in 1993, when the morcellators came in, everyone was merrily morcellating for 2 decades until US FDA discouraged the use of power morcellation. And now everyone has gone full circle, and now we do vaginal retrieval but contained. And that is what I wanted to tell you, Prakash. Contained vaginal morcellation. The techniques we all know. Sometimes the uteri can be removed intact, or large uteri can be reduced by bivalving, wedge dissection, coring, ribbon technique, and also vaginal morcellation. The coring technique, as you can see, and the bivalve technique, which all of us are familiar with. This is a patient who had a 34-week size uterus, and you can see that the whole uterus is completely in the abdominal cavity. After doing a good TLH, then I proceeded to do a vaginal morcellation. And you know, Prakash said you can do up to 28 weeks, etc. But can you do a 34-week size vaginally? Yes, you can. And because you can do it with all the various techniques that I described here, and here you can remove the cervix and give it for histopathology. In a morcellation, it's a nightmare for the histopathologist. So with a very good technique, which all of us are familiar with, we can definitely remove large uteri. This is the specimen in ribbon, and this is another patient who had a large uterus, very large. This would have been very difficult, or maybe only Prakash Trivedi could do it. I don't think all of us would have that much of volume of work to manage it laparoscopically. These large uteri definitely you can do per vaginal, and this is another specimen where you can do a vaginal. I've done a vaginal morcellation of all these fibroids and then removed it vaginally. Now, difficulties, of course, are there with a nulli gravida, with a narrow vaginal, suprapubic arch, atrophic vagina, and large globular uteri. But barring these, almost all can be done. And then, as Prakash said, we can can you remove all those dirty-looking fibroids through the vagina? Yes, you can, through a beautiful contained transvaginal removal, where you use a CCL ball, take an incision, put in the bag from there, put all the specimen inside the bag, and then do a contained vaginal morcellation through the posterior colpotomy in myomectomy and through the vagina. Unfortunately, my EDP guy who has my videos has got COVID. So I'm showing you courtesy Mayo Clinic. My daughter sent me. This is a bag which can be, I think this is the Alexis bag, introduced through the vagina, folded, opened up, and these large specimen then can just be put into the bag and then retrieved from below. It's a very simple procedure, much simpler than using all those tails and tools, etc. of the in-bag. And then you can check the bag. So all large specimens can be done through the bag. So what is my case against in-bag palm oscillation? The indications we know were to prevent dissemination of occult malignancy and prevent dissemination of benign disease like endometriosis, parasitic leiomyomas. You see, we are not spinning the tissue inside the abdominal cavity while doing a vaginal morcellation. We are delicately taking it out. And if we do through a vaginal bag, then we don't have to do it transabdominally and wide incision at all. And when, Prakash, when you are saying large incisions, yes, you have to take so many incisions and widen the bag when you're wanting to do a in-bag morcellation, palm morcellation. So my case is for vaginal morcellation, but contained in these cases. And then for malignancy, you do a proper patient selection. You take care of the age, cervical screening, endometrial tissue sampling, and risk stratification for LMS. And 98% of the cases, we will know atypical fibroids before we even attempt. And those cases we can do in-bag. But vaginal in-bag morcellation. And this was a wonderful study in 2017, where the Agency for Healthcare Research and Quality said that they studied data from 160 studies and 136,995 women who had surgery for symptomatic leiomyomas. And they found that the risk of unexpected leiomyosarcoma is only 1 in 13 per 10,000 surgeries. So why do we want to go and do a difficult procedure? It's like catching the ear from the other side, when you have a simple procedure of doing it in a contained morcellation through the vagina. Leiomyosarcoma is only 7 to 8% of all uterine cancers, approximately 60% present in stage 1. The overall survival rate is less than 40% at 5 years, even if you do it open, vaginal, or any other way. And stage 1 and stage 2, even with intact removal of the uterus, there was a 71% recurrence in 2 years, and the overall survival after diagnosis is only 52 months. So therefore, there is not so much of a risk for the lawyers to come in. And now, what about the difficulties and complications? First of all, there's a very steep learning curve. All of us are not Dr. Prakash Trivedi, who's a phenomenal surgeon with large volumes of work, and even he has a problem. And also, very often the bag gets twisted, and you can't put in your morcellator, and then you and your assistant are twisting yourself out of shape trying to untwist the bag. You can't do very large size uterus. There's puncturing of the bag with the tenaculum, suboptimal visualization, and of course, histopathology's nightmare is an in-bag morcellation. So vaginal morcellation, dear friends, is the way to go. And primum non nocere, first do no harm, and that is well met with vaginal morcellation. And its vaginal morcellation is like Virat Kohli hitting a sixer to win the match. I rest my case. Thank you.
So thank you very much. Thank you very much. At least both of you agree it's morcellation in bag, whether it's a power morcellation or through the vagina. So different routes. One is trying to play cricket, one is trying to play hockey. Can I ask my co-umpire to give some comments, Dr. P.K. Shah, before we go to the third umpire? And audience, please start voting whether you want to vote for in-bag morcellation, power morcellation, or whether you want the removal through the vagina.
After 1 minute rebut, no?
Yeah. You're getting 1 minute. Don't wait a second. After PK Shah says as a word.
Go back.
PK, you're muted.
I think both the speakers, Dr. Prakash Trivedi and Dr. Kiran Koilo, they did a fantastic job to convince the audience that is listening to them. And I'm sure after the rebuttal, we will have the final decision made before we decide whether we should go to third umpire or not.
Stop the slide share.
That is the opinion of umpire PK Dadiwala. And here Prakash, rebuttal. Yeah. Prakash, your 1 minute starts now.
Yeah. Now, first of all, I think so Kiran is very much lost. First of all, she didn't have a single film of hers to show.
I told you, my man had...
No. She went to somebody else. And imagine a 20 centimeter fibroid. What colpotomy and what bag she's going to use in a nulliparous or an unmarried patient. I mean, we are not daydreaming. All of us are intellectuals.
And she was mostly talking about hysterectomies, not myomectomies.
Yeah, and you don't know an undiagnosed tissue. We are talking of any undiagnosed tissue, fibroid, uterus, ovarian, etc. Any mass, put it in the bag or go to the court. What I'm trying to give an idea is, don't go. We have greatest vaginal surgeons here who also agree that doing a good in-bag is excellence of surgery. Adding vaginal removal of an intact specimen is a different thing. The moment you start slicing and coring, cells are going inside and it can go inside. And I'm a little bit surprised, Kiran, but I think so the audience would have a clear idea. Understand that if you know in-back morcellation properly, whether you will prefer in-back till 2014 we did 11,000, another 1,000 we have done now with in-back because we have changed the change is an essence part of the progress. Kiran.
All right, Prakash.
So your time stops now. 1 minute to Kiran to rebut to what he says now.
Sure. Now, the brief which was given to me was vaginal retrieval. And my take is vaginal retrieval in bag for all the large fibroids. It is doable. I don't know. Unfortunately, my EDP man had COVID, but I have designed a bag where I use a indigenous bag, tie a string around it and put it and take all these vaginally. Yes, certain cases are not possible, but like that, certain cases are not possible even in-bag morcellation, power morcellation. But why use, when you are used to a vaginal route, why? And do you know how many complications there are with in-bag? As I said, not everyone is Prakash Trivedi. And you have to do 11,000 cases and still he struggles sometimes at conferences. I've seen him. All right. So it's not.
And cancer is very rare.
And
cancer is very rare.
Cancer is very rare. You can rule them all out. And you are not spinning any tissue when you do a vaginal morcellation. So that's just to say. And as I told you the statistics, there are hardly any cases. It's like taking a very big hammer to hit a very small ant when you do a in-bag morcellation. And so many cases of rupture of the bag and trauma, etc., even in very experienced people. And we are talking about, you can even take an elephant through the vagina in hysterectomy very easily rather than put it in a bag.
So that is great. She wants to take an elephant out of the vagina.
Why not? You can do it.
So that's hitting the ball out of the stadium. The ball has gone out. It has gone out. The elephant has been hit out. So let's hear the opinion of the third empire. Audience, please be ready to vote. Please vote as much as you can, and you have the vote for with laparoscopic bag morcellation or vaginal retrieval.
Yes, sir. I think
Naren.
Absolutely great.
PK Shah, sir.
Naren,
Yeah.
I think you conducted it so well. You did a good job as umpire. But I would like to make one thing very clear, that after listening to two stalwarts in the field, you must know what are your limitations, what is your experience, and what is your competence. By listening to someone, by looking at some films, you can't start doing things. You must have a good quality morcellator. You must have a good experience like Dr. Prakash Trivedi. And as we all know, we do it basically for medical legal purpose, to save ourselves. And that is the reason we do all the fibroids morcellation in bag for the last couple of years. We all know the reason. But at the same time, when Dr. Kiran was supposed to tell us about vaginal retrieval of specimen, I think she did a good job. That she has told that no size of the uterus matters. Now, of course, she totally went into hysterectomy part. Also, no size of the tumor should matter according to me if you are a good vaginal surgeon. All of us have done big size vaginal hysterectomies. We are so confident and we can teach now people. Unfortunately, the younger generation doesn't know how to remove all the uteri vaginally, even non-descent vaginal hysterectomy. Majority of them resort to laparoscopic surgery. So I think we leave it to people, depending on the facilities available, depending on their expertise, they should decide what they should do in their private practice.
So
you.
it seems this match is heading towards a super over. And if it is a super over, if they vote almost equally, which I think they are going to, then we will give them 1 minute each more.
Both of us are very happy that the empires are too impressive. One white royal Rajwadi look and one the typical North Indian look.
And very, very experienced
Yeah.
umpires.
Thank you. But it is a match between you guys. It's not our match. We're just going to make sure that you guys stick to the time and stick to right. Okay. So Niranjan, the second match.
Yeah, absolutely great, sir. Wonderful umpires, and I would like to thank Dr. Prakash Trivedi, Dr. Kiran, madam, to be there today. And it's a weekday, in spite of your busy practice and all of you being here. We are looking forward now to the next power play, and I hand over the mic to Dr. Narendra Malhotra and Dr. P.K. Shah, sir.
So here we are with the second most common problem post-surgical in women, wall prolapse. And wall prolapse, whether you're going to put a scope and pull them up, or whether you're going to take a big needle and stitch it up from below. That's what these two are going to say. It's Delhi Capitals versus Mumbai Indians, and it was Mumbai Indians 1 versus Mumbai Indians 2 in the previous match. And let us see what Delhi has to say. Nikita, it is women versus men, and my vote is already for you.
So sweet.
Whatever you say.
So
So here's a biased umpire.
always. You've always been biased towards me.
So your time starts now. It's 6:32.
So 1 second, let me just get my slide ready. Let me just share my screen.
So, ladies and gentlemen, I hope you're enjoying this great match which is happening. The series which has happened, the fourth one as now. And now Nikita has got a slide. So your time starts now, 6:33.
Okay, so now we're talking about wall prolapse. One of the most common things why this wall prolapse happened. With wall prolapse, what is the ideal route? We say laparoscopic sacrocolpopexy. That is the gold standard. Why? Because in the etiology of prolapse, it has completely changed. We used to say earlier that it's chronic cough, chronic constipation, vaginal deliveries. But now we know that the most important thing is the collagen. If the collagen is not proper, we operate in Dubai in many nationalities, and we find that in Arabic patients, it's difficult to do an NDVH even after 8 deliveries. Vis-a-vis Indians and Pakistanis, where after 1 delivery, everything is coming down. So the endopelvic fascia is the key to the management. So today we know that the 3 levels of support which are there, the endopelvic fascia or the level 2 support is what is most important. The puborectalis muscle is most important, the levator ani. So long as that is anchored well, you will not have any issues with the subsequent prolapse. So endopelvic fascia should be replaced very well. Now, we know that when we do the vaginal axis, again, first is the fascia, second is the axis. When we do a sacrocolpopexy, we are restoring a near normal vaginal axis. We know that it will go towards the S4 or the sacral promontory at that level. Whereas when we do a sacrospinous fixation, we know that there is a posterior deviation of the vaginal axis. When we do a pectopexy, there's an anterior deviation. When we do a sacrospinous fixation, there's a posterior deviation, leading to most of the issues of having stress urinary incontinence, anterior compartment defects, etc., etc. So we have to make sure that all the compartments are looked after in one go. We want to avoid a recurrence. So how do we go ahead with a wall prolapse? With a wall prolapse, we know now that when we see this, when we do a wall prolapse, we are doing we're looking at the exact defect, where it is, and with that defect, we will replace the defect with a firm tissue, with an artificial implant, whether it is a fascia lata implant, whether it's a Prolene mesh, whatever it is. And today we have dynamic meshes. We have 3D meshes, dynamic meshes. All those are there. So here what I'm doing is I'm dissecting the wall. I've got a sponge on a holder, simple sponge on a holder inside the vagina, and dissecting this nicely, going down. Anteriorly, you must go down And bilaterally, you don't want to have a triangular defect repair. You have to go bilaterally up till both your both your ureters are seen. Posteriorly, you will go down till you dissect it completely. And in my defect repair, I always, whether it is wall prolapse, whether it's nulliparous prolapse, whether it's normal prolapse, it is a pelvic floor defect repair. Endopelvic fascia has to be replaced. So what you are going to do, that is the basic concept change which has come in now. So we have to make sure that fixed points, here I'm exposing the sacral promontory, fixed points are there, sacral promontory, levator ani, these are the fixed points which you show, and then that vault which I had, you can anchor that in wall prolapse. If you have, like this is a case of nulliparous prolapse. Again, nulliparous prolapse, wall prolapse, everything is pelvic floor. So once your pelvic floor, this is the same plane as we use in rectopexy. This is the transmesorectal plane. I'm going under the rectum here. And the first thing which I'll see is the piriformis over there. So you can see, you're not doing any blind procedure. You're seeing properly, you're replacing the defects which are there. We all studied in TLN that you have to see the defects and repair the defects. Now, laparoscopy enables us to see those defects and repair them adequately and go down till the thing. And also teaching with the fellows is so easy. Here you can see I'm going between the rectum and the cervix here. Between the two layers of the non-villous fascia now, and I'll be exposing the levator ani bilaterally. So firm anchoring into the areas which need to be repaired. So levator ani is a fixed point. Here you'll just see without having any compromise on the vaginal axis. Sacrospinous, the vaginal axis will go very posterior. Sex is a problem. Stress urinary incontinence is a problem. Whereas this, there is no sexual problem with the patient later on. And no incontinent issues. If you have someone who is free, we had the CARE trial which came in. And in the CARE trial, it was said very nicely that if you have anterior compartment defects, they had divided them into two parts. One is with the Birch-Colpo suspension and the others without a Birch. So if you have a pre-diagnosed wall prolapse with SUI, they did a Birch-Colpo suspension. And whether you can do it without Birch, I'll just show you how we can keep a mesh anteriorly very nicely in wall prolapse. So here you can see I've exposed both the levator anis and I'm keeping a mesh. If you try to keep this mesh vaginally, you will have so many difficult to manage complications, and vaginal mesh is banned. Of course, US FDA is a name I'm very scared to take in front of Prakash sir, but US FDA has banned it, and we have enough trials to show that vaginal mesh is a mess. You have abscesses, you have erosions, other things. So you have to keep the mesh laparoscopically. You have to see fixed points. These are the two levator anis where I'm going to keep the mesh nicely, anchor them properly, dissect it properly. So you can see the rectum, you can see both sides, you're dissecting properly, and then keep the mesh, anchor it to the sacral promontory. We have soft mesh, we have 3D mesh. Now I've started using stem cell on the meshes. I'll just show you that procedure where we take the stem cell and then we put that on the mesh so that the mesh rejection is lesser. So laparoscopic mesh is the ideal mesh repair because you're using fixed points. What does the guidelines have to say? Now this is the nice guidelines. Stress urinary incontinence is much higher and you have other complications. Sex and stress urinary incompetence is something which we have to be very careful of. CARE trial and Opus 1 study showed that if you have this, you have to make sure that you do the dissection anteriorly. I'll just show you the anterior dissection of this. How we can do the anterior dissection till both the ureters, and you keep the mesh down. So if you have SUI, you can handle it with an anterior mesh also, which you can put at the same time. Now this is a wall prolapse where I've put the posterior mesh for the posterior compartment and anchoring it to the cervix, and then I'll put the anterior mesh. I'll go faster on that.
1 minute more.
Oh, no. I have a large study to show. So should I just skip this? This is the anterior. This will
You have only 7 minutes to tell your.
So this.
You can say it in your 2 minutes later.
Okay, thank you. So we have this anterior compartment. You can see anteriorly I've dissected right up till the trigone, and I'm putting this mesh anteriorly. This will look after my SUI component also. So respect the transmesorectal plane. This is the plane. If you don't touch the nerves now, a lot of people say that the nerves, if you have constipation and other issues, if you keep a good endopelvic fascia, keep the fascia over the sacral promontory, don't go bearing the bone, and if you don't damage the nerves, you will never have constipation. And keep a loose mesh. I cut the mesh in between. This is Dr. Hafiz's method, which I also follow. This is a large systematic review of 3,414 women with 13 studies, and you can see that this was a meta-analysis, the systematic review of several meta-analysis, and what it showed is that the failure rate is much higher.
Time up, madam, time up. You can come to these studies in your 2 minutes, which you'll get. You'll get 2 minutes more after Dr. Sarogi speaks. So, Dr. Sarogi, it is not
stem cell procedure on the mesh. Just a stem cell procedure. This is how I make the mesh better. And lots of devices now, ProGrip, etc., which has come. So, all my last remark is: if you can't change the girl, change the girl. Ye mat karo. Learn the ideal procedure.
Dr. Sarogi, if you can't change the girl, you can change the girl, and you need to know your boundaries. So your 6 goes correctly on the correct boundary, and not blindly. If it goes blindly, it will just entangle a nerve. That is what she wants to say. Can you stop sharing your slides, Dr. Nikita, so he can come over?
I'll request Meenakshi to share my.
So yes, you can start sharing your slides, and your time starts now. It is 6:43.
Good evening, everybody. Good evening. I'll require 8 minutes plus 1 minute rebuttal. Greetings from Mumbai. Good evening, everybody. First and foremost, let me thank Dr. Niranjan Chavan for such brilliant idea of inviting us for yes, Dr. P.K. Shah and Dr. Narendra Malhotra. I'm sure you will be unbiased as your opinion becomes. My opponent is a charming lady, fair sex.
That's not the reason for bias.
I thank all the delegates who are attending this program. My talk will be wall prolapse repair should be done vaginally. Next. God has given us 5 sensory organs: eyes, nose, ears, tongue, skin. I do agree with Nikita. But what about touch? Touch sensation is never there in a laparoscopic surgery. Next, please. It's a natural route and not an artificial. It differentiates between a gynecologist and a general surgeon. Here you can see that's the abdominal, vaginal, and this is laparoscopy route. Next, please. This reminds me of Chulbul Pandey's dialogue. I will make so many holes in your body that you will be confused from where to breathe. And next, please. Done under regional anesthesia, you can see how the anesthetist is comfortable and giving spinal. Next, please. Look, young man, I clearly asked you to put him on oxygen, not hydrogen. These mistakes can occur with GA in laparoscopic surgeries. Next, please. Condition of the anesthetist is relaxed. Next, please. Look how confused and worried anesthetist is. Next, please. Position of the patient is slight Trendelenburg and not Shirshasana. Next, please. Here, surgeon is telling the patient to give Shirshasana position. Next, please. Even a registrar gets a chance to do it. Not the case even after post-graduation. Next, please. Taught learning curve. Next, please. I have done this surgery. Of course, this is not applicable to Nikita, but for others, several times in workshop, never seen this much bleeding. Those were cadaveric workshops. Next, please. Next, please. And this is what happens when you do 3 days course or 7 days course in laparoscopy. It's a conventional surgery. Next, please. Next, please. Next. It's cheap, meant for masses. Why it is cheap? Because remuneration of the anesthetist will depend on less charge, less relaxation. Plus, you have a choice to ask patient, you want 3 cheap high definition camera, you want flexible scope, you want this, you want that, and now even the meshes are also of different types. Next, please. Here the patient is being asked, which one do you want? Next, please. Various prolapse repair. We all know that wall prolapse is always associated with cystocele, rectocele, SUI. So various concomitant surgeries can be done as is. Next, please. This is a season of festival. So patient has full authority to ask you, what are you giving? And here you can say prophylactically, when I do vaginal hysterectomy, I can do your sacrospinous fixation. Next, please. Can be performed easily in high risk obese hypertensive patients. Next, please. No preoperative preparation required. Next, please. Assistant, only 2 nurses are sufficient and not playing an IPL match. Next. Here the patient is feeling that I am watching IPL match with so many people around in OT. Next, please. Can be performed in rural area in camps where electricity is a problem. Standard OT and standard surgeon. Next, please. I have been using these instruments since last 40 years in my practice. No new instruments have come. Next, please. Time required is much less. Surgeon is comfortable sitting on a stool. Next, please. Complications you all know are much less. Next, please. Mesh complication, here you will find, look at this, what is happening to the mesh. Erodes the vagina, erodes bladder. Next, please. Next, please. So much so in exams also, the examiner is asking and the candidate is telling the general things, but examiner is not happy. What he wants is light plane of anesthesia, hypercarbia, high BP, cautery not working are the complications. Next, please. What is happening to the surgeon? The height is decreasing. Next, please. They develop cervical spondylitis. No gas is put, so no question of pain. Next, please. Overall patient satisfaction is much better because there is stitch.
1 minute
no
left,
stitch.
sir.
Next, please. Technology has stopped him from thinking for himself. So we must have biomedical courses also in medicine as a subject. Next, please. Either he has gone or the net is down. Next, please. You can tell the visitors to have videotape. Next, please. Have you something suitable for my husband's endoscopy photo? Next, please. Sir William Osler said, a good physician treats the disease and a great physician treats the patient who has the disease. Next, please. There are many beautiful people in this world. Don't forget, Nikita, you are one of them. But unfortunately, traveling in wrong direction, you can still turn around. Next, please. Let us accept the fact that vaginal route is always the preferred route. If you can't access vaginally, then you can take help of laparoscopy. And if that is also not feasible, you resort to abdominal surgery. Next, please. Thank you. Thank you. Thanks a lot, sir.
So thank you, Dr. Sarogi, for bringing all those cartoons in the debate. And let's hear from Dr. Nikita. She's got 2 minutes. 2 minutes for rebuttal, and then we'll hear from PK Shah and of course hear from Niranjan. Audience, please be ready to vote. Please keep on, the voting lines are open.
So, can I start?
Yes. Your 2 minutes starts now, 6:49.
Whenever, as a surgeon, it's not important what you can do. It's important what
I'm busy in a way now.
And what the patient needs is a very good endopelvic fascia repair. So you can do it better by a laparoscopy. You can replace the endopelvic fascia, and not because it's easier for you to do a sacrospine. I've done hundreds of sacrospinous fixation. Earlier, we all were learned by a vaginal route. I've done a lot of them, and I've seen the problems which happen. And we were teaching 15 years back sacrospinous fixation. But is it a superior surgery? No. The superior surgery, even with the meta-analysis, is the laparoscopic repair because it completely replaces the endopelvic fascia. And the concomitant things like SUI, like other things which are there, it will decrease your recurrence. It will, 5 years later, what happens to this patient? Will she come up again? Will she have sexual problems? Will she have SUI? That is what is important. What the patient needs is more important, not what I can do. And also, laparoscopy is standard now. Most of your debates, sir, was advantages of vaginal versus laparoscopy. We can go on that. Laparoscopy is here to stay, and it is the standard of care. You cannot say that just because of the head low or IPL matches in my OT, there is one nurse and one person who's assisting. And my anesthetist will give me for internal iliac clipping 5 minutes of anesthesia. Is more careful and easier to do that. So it's what you're used to and what your setup is used to. In Bombay,
Time up. Thank you very much for the rebuttal. Thank you for setting some things right and hitting the right boundaries.
Can I go ahead, sir?
Yes, please. 1 minute,
Nikita,
because you took 1 minute extra there.
Yeah, the question is, everyone is not Nikita. Please. There are people who are far below things. There will be complications. Wait for next year's debate. Probably we'll have a debate on vaginal route versus robotic surgery. It's not going to be laparoscopy. It's going to be robotic surgery. That is what I want to say. Thank you.
We've already had that match on robotic surgery, and we saw that 30% of people want robotic. So that was a very good debate, and 30% voted for robotic, which was quite enough. So Dr. P.K. Shah, your comments, please. Unmute, please, unmute.
I'm thoroughly impressed by both the speakers again, and they, in their own way, were both right. Nikita, being a very good laparoscopic surgeon, we all have been seeing her doing all types of endoscopic surgery. We know in your hands patients are safe, whatever surgery you do, Nikita. But as Dr. Rajendra Saraugi very rightly said, that might not be the case for a general gynecologist who is not an endoscopic surgeon. So I think for all of us gynecologists, we must know basic thing, that is how to approach a particular problem vaginally. And once you know that, it becomes very easy for you to go ahead and do the same surgery laparoscopically. So Dr. Rajendra Saraugi, myself, Naren, Prakash, all of us being one generation ahead of you, Nikita, we all still believe that vaginal surgery is an added thing, which one must know, which is an art, which cannot be learned in 2 days, 5 days. When we were residents, it was vaginal surgery, and vaginal surgery. In those days, in 77, there was no laparoscopy. And we used to get abdominal hysterectomy at the end of 1 month, at the end of one post, abdominal hysterectomy in those days. But vaginal surgery is something which we have learned right from beginning, and we are very comfortable doing any vaginal surgery for that matter. And that is why I think it is up to, again, the experience of the person, the way a person has undergone training during MD, DGO, and the confidence, whether you have a good set or not, or you can mess up a patient if you don't know your anatomy well. So when Nikita is doing some surgery with mess, there is no mess as such. But you have to be very careful when you are using all this synthetic material in a woman's body. I think you both have done a fantastic job. Yes, Prakash.
Can I take some expert opinion from Dr. Prakash?
Nikita,
Yes, sir, you can.
One thing what I want, all the people here are very talented. All of us are minimal access surgeons. Now there is a gross misconception. Now let me make it very open. There is an unfortunate belief with vaginal surgeons. Those Sirishit, Paidungat, they know I have removed 28 weeks uterus, 2 previous Caesar vaginally for an American patient. there's a misconception that a laparoscopic surgeon doesn't know.
Exactly.
50 to 60% of laparoscopic surgeons are excellent in vaginal surgery.
Exactly.
So they have added in the armament. I will obviously agree with Sarogi sir, but the type of anatomy you can see with a 3D in the pelvis, identification of fascia, placement of the fascia. So I think there's a broader message with the permission of two smart empires. I think so you have to draw a level wherein the generation learns vaginal surgery, because nowadays people are not getting any work in any hospital. And then also add laparoscopy. So I think so both should be considered at minimal access, not competing. That is why we made images. PK Shah will remember. It was Indian Society of Minimal Access Gynecological Endoscopy and Vaginal Surgery.
So that is exactly what these debates are meant to convey. It is not one technology versus the other. It is how you integrate both the technologies to the best of it.
So only one last comment can I make? One
Yes.
So if it is my sister or my mother, what will I do? Will I do a sacrospinous fixation? My sister has to have it. I don't want her to have SUI and have sexual issues later and have a recurrence after 5 years. I will want a mesh thing and give her the thing. So why every patient should be treated like your sister?
Yes, Nikita.
That's a great argument. That's a great argument. If the best technology is there,
Narendra, may I make one comment?
One closing, Kiran, before
yes.
if you permit. That's a very important point. I have operated my wife did her laparoscopic hysterectomy on 16th June 2016 with a very large lipoma. I have operated my sister also for laparoscopic surgery. I don't want to name one more person whom I operated and another person whom I am going to operate. What she is telling is absolutely right. I have told this to Professor Durusha many years back. A patient in Rajawadi and a patient in my hospital or Jaslok or Fortes all are the same. And as I told you, an American patient who came for laparoscopic surgery, 26 weeks uterus, we did it vaginally because you could read through the uterine. And then I was afraid to tell ki we have removed 58 fibroids. So there are plenty of good laparoscopic surgeons who are very good vaginal surgeons. And it was fun, Kiran. Kiran, with interacting with you, we did hardly look at the debate.
I know, but may I make a point?
Yeah.
You know, all of us learnt vaginal surgeons. We are all vaginal surgeons first and now laparoscopic surgeons. But what about the young generation? There is nobody to teach them vaginal surgery, and which is why these debates are very important, because the younger generation, we are teachers, we know, none of them know how to do a vaginal surgery. All of them are only knowing laparoscopy, and if they are in trouble with laparoscopy, they cannot bail themselves out because they don't know vaginal surgery.
Actually,
that's why vaginal oscillation is very important.
Please taught us vaginal surgery first, and we did vaginal surgery for ages.
Nikita, no, I'm not talking about your generation. I'm talking about one generation below you.
But Kiran, one important thing, at least in India,
Nikita, you're also in a generation gap now.
Narendra and Kiran, the most important thing in America, Japan and all, they don't see vaginal surgery. At least in India, there is no option. In fact, just look, they know that whenever I'm in hurry, they know that, okay, 24 weeks hai, 16 weeks hai, sir, niche se hi kar dalenge, if I am in hurry. So the point is, there is no debate because vaginal and lapro complements each other. A good vaginal surgeon can massively improve quality of surgery through the 3D scope, 3D vision, because basically, sir, somebody like Sarogi sir and all are phenomenal. I remember Neeta Varti used to learn Vardhams from her. So I think so. He knows the entire thing. PK Shah also does fantastic Vardhams. So they can really guide.
Your city now started Sunrise in Mumbai also. So expecting all of you to help me in Mumbai. Sunrise Bhandup 250 bedded facility has started.
Having COVID also there, na? COVID may be here.
COVID.
So okay, friends. So these people come back to bat all over again. Niranjan.
So umpires holding up
from the empires.
Today all of us are Mumbai Indians.
So umpires are holding up the finger now.
Yeah.
Dr.
Niranjan Shah.
Sir, I'm not Dr. Shah.
Niranjan, you're the man of the match.
Chauhan. PK Shah, I was saying.
And I'm okay with it because working with Dr. PK Shah, my surname has become Shah.
You are half shy.
So that's really
I think I remember once PK Shah told that there are many Shah, Badshah, but there is only one Sahan Shah. I think so. You had told once when
my
Dr.
God.
was there. But
My God.
whom
But
will
it is
get Shah,
amazing,
Badshah, and I will not tell the details.
to have all of you here. We have got various, generations being here. Nikita Train, I am with you. You don't have to worry. They are all overpowering you. I can see that. And there is Dr. Prakash Trivedi, who is also with us. And there are many googlies and bouncers which have occurred today.
Nikita
And
is not a person who gets worried.
Let's
He-
let's hear
and
some
you have
comments.
hit a sixer. I can tell you the results are out. But it's
Niranjan,
okay.
let's hear
Whoever
some
wins,
comments.
it is not the
Comments from the
issue.
audience.
I want to read some comments with Dr. permission of Dr. Narendra Malhotra and Dr. PK Shah. Sir,
Yeah, go ahead.
uh, there is one person, Dr. Somil. He is saying in between again and again, vote for laparoscopic back morcellation, vote for
That is nepotism. That is nepotism.
No.
Other way around.
Oh my God,
Kiran,
we don't want to use that word here.
he was worried about vagina. When you do vaginal bag, it tears off. It tears
Did
off,
he-
and vaginal
did he
bags
say
are having
vote-
both side mouth open.
Did he say vote for
No, you can put
laparoscopy
a
or did he
string
say
around
vote
it.
for dad?
No, he said vote for laparoscopic morcellation, sir. Please let me read the comments.
Yeah.
And I don't want to use that word here quite often, and it's not right. It's absolutely fair. It's a wonderful debate which we have gone through, and there are 1,854 doctors who have logged in today. Amazing response
Very good.
to today's
Very good.
topic and the panelists. And we have got great performances from both of the power plays which have been done. This is Dr. Tahira Alauddin from UAE. She is watching IPL and she is watching EPL. That's amazing. And she has congratulated Dr. Sarogi. Hilarious presentation. So many presentations. I'll tell you, Dr. Sarogi is a man. He's a book, actually, you can say. And when his presentations are there and his videos are to be shown, he's amazing. But today he was on a very different note. Today he has hit the ball at a right, proper, timing, and it has gone beyond the stadium, not only beyond the boundary. So this is what is Dr. Sarogi, and you can see his enthusiasm of so many cartoons which he has.
Chris Gale, international gynac.
Yes, international vaginal surgeon, and we want to tell EPL that we are going and we are getting the best of the lot, the best of the people, and there are more than 1,854 people logged in.
Very good.
This is Dr. Kaveri from Jabalpur. Superb, both of you. This is, I think, regarding the last Power Play 2 debate. Dr. Madhulika Singh from Varanasi. She has also said endoscopy was beautiful, and she is saying hands down to laparoscopy and endoscopy. That's the new thing, the new kid on the block, and the robotic surgery. Sir, this is what the audience says. Dr. Milind Kolvalkar, he's from Goa. Excellent debate. It's a complete treat to the eyes and ears. Thanks a lot. He thanks the umpires and Dr. Narendra Malhotra, Dr. PK Shah. You have come back again after being a COVID warrior. It's amazing to see. I can also find here comment from Dr. Pawan Dheer, sir. He was one of the umpires in the previous section, and he has said, Niranjan, wonderful. Dr. Niranjan Chavan, you are doing great. Dr. Nazia from Gorega, what a match. This was more entertaining with science and hilarious. Then we have got Dr. Anuradha Garad from Usmanabad. Excellent debates. Dr. Rekha Rani Agra, very good umpiring. Dr. Narendra Malhotra, one more from Dr. Rekha Rani. And this is Dr. Suvarna. I loved the umpires and all the panelists. What a choice of people. Thank you, Dr. Suvarna, for that wonderful comment. And really, we are very, happy to see them here. And especially the ending and the conclusion which Dr. PK Shah and the starting with Dr. Narendra Malhotra does, and the synopsis is too good. Dr. Ravi Chandra from UAE, again, EPL on one side, IPL on another side. Good debates. Then this is Dr. Rathi from Amravati. Khub Chan. Two good discussion. I can just go on. And I want now the results to be said. I think Dr. Narendra Malhotra, you might have got the results by now. Dr. PK Shah, it was a very tough fought match and the
Yes.
counting was still going on. But I think we have to respect the viewers and the audience. But still, I will ask and hand over the mic to both of you. This is Dr. Asma Rana from Nepal. This program should now be conducted in Nepal also. Madam, we are in Nepal right now. You are also there. We will get one of the speakers from there. Dr. Narendra Malhotra will be kindly helping us in that. Thank you, Dr. Nikita Trehan. Why are you so putting your hand like this? Oh my God! You feel that you lost the debate. Well, I don't know. Narendra Malhotra will say. Dr. Prakash Trivedi, Dr. Kiran Koilo, Dr. Rajendra, Dr. PK Shah. Thank you so much.
So, great debate. Congratulations to all the players. Fantastic discussions. It is new technology versus the laparoscopic technology versus, which is not new now, but morcellation and mesh and all people feel are still new and still feel what I can feel the pulses. Still everyone can't do it. And still people want I think then a lot of people who are vaginal surgeons have probably watched and not the younger ones. So 30% want to do in-bag morcellation laparoscopically, 70% want to do vaginal retrieval.
Oh.
So that's what it is. But 30% are ready to put the bag in and morcellate within the bag. I've also just started. Prakash, even me, have just started in-bag morcellation just last year. So
may I come into the fray that I'm doing in-bag morcellation for the past 2 years.
Yeah, she's doing. That's what I was about to tell. We discuss a lot about it back.
Yeah.
It's a big change which is coming. Similarly, with the second match, it is the vaginal surgeons who overpower the match, and it is 20 to 80. So 20% want to do laparoscopically mesh, and rest 80% want to do just put the wall stitch on the wall, and that's it. So they feel that is simpler. So that
Rajendra.
What I feel is the simplicity and the technology. And what I feel it's going to be a shift of technology, and people are going to use technology to their best.
Only one point, Narendra. The big message, as PK sir also rightly pointed out, don't take removal of any size fibroid, any number of fibroid through a colporter. Don't believe in that. Removal of uterus is a different issue. Removal of fibroid is a different issue. We have to respect our patient. It is better to have once in a while difficulty out of 1,000 cases rather than not treating them properly at all. But we enjoyed the debate. It's always fun to enjoy the debate.
Lovely debate. And
I'm happy to do it with a colpotomy.
20 centimeters.
Yeah, I'll tell you.
20 centimeters.
I would never do it.
20 centimeter, which colpotomy? How will you do?
No, which colpotomy?
No, you can morcellate the sample in the bag, of
Private
course.
debate
I have used bone cutters sometimes from vaginally.
Outside the boundary, so it is becoming even more interesting.
Now we all are Mumbai Indians.
I think the audience will get more confused if we see dissect it further.
Pavilion all over again.
No, Prakash, I've had hard fibroids which will break the morcellator. We have done it vaginally through bone cutters.
Bone cutter, oh my God.
I have spoiled 4 morcellator and then widened the issue because the specimen was in the back. It could be removed comfortably. But anyway, I have a meeting with a lawyer, not the lawyer for bag, but I am meeting with a lawyer for some new property I'm taking.
Prakash, we have enjoyed the debate with you.
Very much, everyone.
Pleasure.
Conclude.
Lovely Niranjan, lovely PK sir,
Lovely Niranjan, thank you very much.
Very good. Very good.
Narendra,
All 4 of you, very good. Niranjan, thank you.
Sir, can I read some comments, sir? We are still not winding up. Please.
Go ahead. It's all in.
Dr. Geeta Sardar Singh Shevgan from Aurangabad. Fantastic. All 4 panelists and umpire match was mind-blowing. She's from Aurangabad. Dr. Taira Alauddin, UAE. I am honored to work with both of you, Dr. PK Shah and Dr. NNC. Thank you, Dr. Tahira. It was a pleasure to join with you. Dr. Rajiv Dhal from Kolkata. Great fireworks before Diwali.
Good one.
Dil mange more, says the audience. So we will see the audience and the umpires in episode number 5. And thanks a ton for all of you. You're great people. And I think India is still in the region of vaginal surgeries, as it was told by Dr. PK Shah in our residency. Still now also we start with vaginal surgeries. And of course, there are technologies which are there, newer kids which are coming up on the block, and we need time and we need that much amount of, the patients.
Only one thing can I say, sir? Only one thing. Prakash, sir, you must have seen maximum number of patients you also must be getting, I must also be getting, is for gynecologists who want their relatives to be operated. So they'll do all this in other people, but when it comes to wall prolapse themselves, they will want to operate on.
Nikita, in the broader sense of term, we have 40,000 gynec. Of which there are 200 expert laparoscopic surgeons. So you have to understand, people to vote for vaginal surgery. Otherwise, who will vote for removing fibroid of 20 centimeters to colpotomy? But it is
how you are famous.
And every person young wants to learn both. So that is fine. That's fun.
Actually, knowledge is infinite and we want to learn more, and that's why people are joining to learn. They want to see the videos. Nikita, your videos were amazing. Dr. Trivedi sir, your videos were too good. And the way you have even degenerated fibroid, removed it in a bits and pieces, that KCF material, it is something very important. But I think most importantly, people have to change their mindset now and shift from one aspect of vaginal, go towards further ahead, start using endoscopes, hysteroscopes, add them in your armamentarium. That is how I would put it in broader perspective, so that in the next 5 years, 6, 7 years, you are much better skilled than Dr. Sarogi, then Dr. PK Shah, then Dr. maybe any other gynec surgeon.
Probably I may not be.
Yes, and that is what we need to do. We have to have new iPhones which are coming, newer technologies which are coming. We have Google Home now. We have something like home is automated, everything. So we are shifting. So
Niranjan, one point, and Nikita, PK sir, and then Sarogi sir and Narendra. You know, the best part about the world is how India is great. India is most popular for vaginal surgery, for masters of laparoscopic surgery in America. So AHL respects India as the biggest country doing the largest number of big myomas, difficult surgery, cancer surgery, as it was popular for remove tonsil from the vagina. So I think so. What is very important, PK sir? Yes, sir, you want to tell something?
What is important? Even though we have the best endoscopic surgeons in our country, there is a lot of competition, number one. And number two, we do not publish the work done by us in international journals. That is the reason people do not know what we are worth, whether it is vaginal surgery, whether it is endoscopic surgery. So what is required of us now is that we must publish.
Yeah.
We must publish.
See, the bad thing we have published, and PK, most important thing is COVID, that you can have cigarette, you can have cigar, you can have shisha, you can have hookah. I'll take away your smoke into a smoke evacuator, you will not get lung cancer. Our work on how to do laparoscopic surgery in COVID time, 60 plus cases, including all surgeries, is already taken for publication in a very big journal. And they are going to take a turn and learn how we should do laparoscopic surgery in COVID time. So that is what precisely we are trying to tell this. We have learned from our teachers only. But what has happened is the level of teaching of laparoscopic surgery, people get a little bit more glamorized. unlike vaginal hysterectomy. And what is happening is in teaching hospital overall work, except Sion Hospital or a couple of others, every place doesn't have that much of
No.
work.
But now, I'll add one point for vaginal surgery and vaginal hysterectomies. You know, pain was an issue because we used to use sutures, but now we can use the advanced bipolars, etc., and the patients are very happy. I still do most of my cases vaginally, even non-descended, and this is the advantage. And
So I would
many
like
people
to
from the
end now with
West,
few
in
more
fact,
comments.
I still remember the surgeon brought his sister down for me to do the vaginal hysterectomy.
Dr. Trivedi, sir, you wanted to say that's last comment, and then I would like to wind up with few
No,
comments.
no, I am giving a thumbs up and I am leaving because I will meet that person and then a patient. But it was enjoyable. It was lovely.
We enjoyed it
Great.
thoroughly.
Thank you very much.
Thank you. This is Dr. Reena Shrestha from Nepal. Great to see Nikita, ma'am. Nikita, this is for you from Nepal. Dr. MC Patel, Ahmedabad. Congratulations. Narendra Malhotra said east, west, north, south. India is the best. And it is a wonderful to have the bottom of the story or the highlight of the story. Most important, please adapt to the newer technology as much as possible. That's what we can come to the conclusion, and improve your armamentarium by adding those tools. And obviously, you have to lean back to vaginal surgery if required, maybe abdominal approach. And I thank all of you to be here today. We will be waiting for the episode number 5. Dr. Narendra Malhotra, thank you. Dr. PK Shah and all of you who have
Thank
been
you.
here with us. Thank you so much. I would like
Yeah.
to thank Science Integra, Subbu, Minal, and Sun Inca to get us, all of us, the audience together to see this wonderful EPL. Thank you so much.